Welcome to this two-part lecture series, Lung Anatomy and Physiology, along with early identification of infection. Let's get started with lung anatomy and physiology. There are two types of chronic lung disease. One is COPD, chronic obstructive pulmonary disease. This simply means that you have difficulty getting the air out. You feel like you need to breathe in again before all of your breath is exhaled. The most common obstructive lung diseases are chronic bronchitis, emphysema, asthma, bronchiectasis, and cystic fibrosis. With restrictive lung disease, you have difficulty getting the air in. And the most common restrictive lung disease is interstitial lung disease, but restrictive lung diseases cover many other conditions too. Symptoms of chronic lung disease, whether it's obstructed or restricted, may include the following. Shortness of breath. You probably had that for a couple of years before you were diagnosed with a chronic lung disease. You attributed it to aging, gaining weight, being inactive, when in reality you did have this chronic lung condition that was progressing. Chronic cough. It could be dry or have sputum. Wheezing, maybe too much mucus. Colds that last for weeks instead of days. Feeling short of breath with activities, and chest tightness. You can live with chronic lung disease and you can live better by learning how to control it, by being an active partner in your treatment, practicing what you learn from class in your book, and asking questions. When breathing problems or infections occur, you'll know what to do. So we're going to talk first about normal lungs and normal breathing. Inspiration, breathing in. It gives your body the oxygen it needs to live. Expiration, breathing out. It gets rid of the carbon dioxide from your lungs, which it produces as waste. Long periods of not breathing lead to a decrease in oxygen and increase in carbon dioxide, which can cause headaches, tiredness, or drowsiness. Remember from the breathing retraining discussion that 75% of the work of breathing should be done by your diaphragm. And if it's weak or atrophied, you need to strengthen it. It's much easier to work with one large muscle instead of many smaller muscles. With your diaphragm, as you breathe in, your diaphragm moves down, pulling the air into your lungs, causing your ribs to expand. It also pushes your belly out when you breathe in because the diaphragm's right above the stomach, and so it pushes down and out on that. With normal lungs and normal breathing, air enters your body through your mouth or nose. It's then cleaned, warmed, and humidified. The air enters your windpipe or your trachea and flows through the large air tubes or the bronchi to your lungs. These air tubes branch into smaller airways called bronchioles, and the airways end in the 300 million tiny air sacs called alveoli. If you were to take all the alveoli out of your body, lay it on a flat surface, it would cover more than a tennis court. As you can see from this picture, your lungs are like an upside down tree. The trachea is the trunk, the bronchi is the branch, the bronchiole is the twig, and the alveoli is the leaf buds or flowering buds. So with normal lungs and normal breathing, you have systems to breathe in clean air. When unclean air enters your airway, your lungs have a system to clean it. The mucus cells make excess mucus to trap those particles. This mucus then comes up to the top of the cilia. The cilia then sweeps the mucus up to your throat where it's coughed out or swallowed. By the time the air reaches your alveoli, it's clean. How many of you are familiar with a smoker's cough? When smoking, the cigarette smoke paralyzes the cilia. So a lot of times, especially first thing in the morning, there was a lot of coughing, and that's because that cilia became unparalyzed, only to become paralyzed again when you smoked that first cigarette. The walls of those alveoli are about as thick as a soap bubble. There are tiny blood tubes or capillaries running through the alveoli. Oxygen easily passes through the alveoli to the capillaries, taking the oxygenated blood to the rest of your body. Carbon dioxide passes from the capillaries to the alveoli, ready to be breathed out as waste. Let's go into some common lung diseases. Chronic bronchitis, too much mucus. As you can see in the bottom picture, the lining of the airways is swollen, and the air tubes itself, the bronchioles or bronchi, are trapped with mucus, or blocked, I should say, blocked with mucus. It's caused by cigarette smoke and air pollution, making you, when those airways are trapped with excess mucus, it can make you more susceptible to lung infections. The bad stuff has nowhere to go, so it stays in your lungs. I'm not cured by antibiotics. The best way to decrease the symptoms and prevent flare-ups is avoid the irritant, especially cigarette smoke. Drink enough fluids, especially water, to stay hydrated. Water will thin out the mucus. Keep your lungs cleared of mucus. Use that Arabica we gave you, and then take the medicines prescribed for you. With emphysema, we call this airway remodeling. The air is trapped, making the sacs become bigger and misshapen. The bronchioles collapse, and then there's less room for the air to come out. Think of this as a balloon that's been blown up too many times. There's still excess air in there. Once you try to let the air out, you have to squeeze it so it comes up and out of the mouthpiece of the balloon. So it just actually destroys your air sacs, causing airway collapse, mostly caused by cigarette smoke, but there is genetic emphysema as well, which is a lack of protein in your body that gives your lungs and also your liver its elasticity. So, especially the cigarette smoke, it destroys the air sacs, the blood vessels, and support tissues that give the airways their shape. And then many of those small air tubes also collapse. So that transfer of oxygen and carbon dioxide does not occur as it should, because that air is trapped. You need extra pressure to exhale. You suffer from shortness of breath and coughing. And in time, your lungs and hearts could become enlarged, and your chest can become rounded. There's no cure for emphysema. Medicines and breathing exercises help decrease symptoms and flare-ups. Not smoking and avoiding irritants can help slow the progression of emphysema. And most people with COPD have both emphysema and chronic bronchitis. There may even be an asthma component in there as well. With asthma, you have muscle spasms, you have excess mucus, you have swollen linings, and you have trapped air. So again, airways are inflamed and swollen, they make extra mucus, and then the muscles in the walls of these airways go into spasms and clamp down on the airways. This makes it hard for the air to flow in and out of your lungs, and it's called a flare-up. During an asthma flare-up, you may cough, be short of breath, have chest tightness, or wheeze. Things that cause asthma flare-ups are called triggers. There are many types of triggers, and they vary from person to person. Common triggers include the cold and flu, smoke, exercise, pollen, pets, and dust mites. The best way to avoid an asthma flare-up is to avoid your triggers and take your medications. Bronchiectasis causes scar tissue from trying to protect your airways from this mucus that shouldn't belong there, and then that thick mucus that can become infected. Often caused by serious lung infections, abnormal lung development before birth or during childhood, or an abnormal immune system. It's common in people who have cystic fibrosis. The airways deep in your lungs become scarred and widen where the mucus pools, and the cilia cannot push this pooled mucus out. Causes coughing, wheezing, shortness of breath, excess mucus. The pooled mucus can also become infected. Treatment includes staying hydrated, antibiotics, pursed lip breathing, and aerosol medication or a nebulizer. Cystic fibrosis, most people are born with the cystic fibrosis gene. It is very thick, tenacious mucus that blocks the airways and leads to lasting damage of the bronchioles and bronchi, which can cause bronchiectasis. Again, treatment includes using antibiotics, breathing exercises, and postural drainage. Getting that your position can help move mucus out of your body. There is no cure for cystic fibrosis, but it can be managed. Continuing advances are offering better quality of life for cystic fibrosis patients. Let's move on to the restrictive lung diseases. Interstitial lung disease. It is a large group of many different lung diseases. These diseases occur when lung tissue becomes thick and stiff due to damage and scarring. Stiff lung tissue makes it hard to breathe, especially when moving around or exercising. And again, shortness of breath is usually the first noticeable symptoms. Some doctors don't know why you may have developed ILD. If they run tests and still don't know why you have it, they will say that it's idiopathic, which just is a big word for meaning that they are unsure of a cause. Or as my medical director says, your doctor's an idiot and doesn't dig deep enough. Little joke there. There are several known causes of interstitial lung disease. First of all, another disease, often an autoimmune disease like rheumatoid arthritis. Long-term exposure to some kind of dust, fiber, mold, or tobacco smoke. Treatment for another disease, chemotherapy, radiation, etc. And then your family history. There can be familial causes of ILD. Treatment for interstitial lung disease includes medication, oxygen therapy, pulmonary rehab, and surgery. I'm going to jump back real quick to the known causes. That treatment for another disease or condition, there are quite a few, let me rephrase that, at least 2 known medications that can cause interstitial lung disease. Macrobid or, what is that? I can't think of the name now. Macrobid is known for its, sorry, I'm trying to look it up here. Macrobid is for urinary tract infections. Let me find the name. Nitrofurantoin. So if you've been put on nitrofurantoin, you may want to ask your doctor about the scarring that it can cause, especially if you already have an interstitial lung disease. The other medication that is known to cause pulmonary fibrosis or interstitial lung disease is amiodarone, which is irregular heart rhythms. It treats that. So very important to try to avoid those medications. So we already talked about this. Lung transplants are for patients up to 75 years old. They've made a lot of advances. We have a patient right now who is about 15 years post-transplant and doing pretty well. Pulmonary hypertension is another restricted lung disease. It's a type of high blood pressure that affects the arteries in the lungs and the right side of the heart. In pulmonary arterial hypertension, blood vessels in the lungs are narrowed, blocked, or destroyed. The damage slows blood flow through the lungs. Blood pressure in the lung arteries goes up, and the heart must work harder to pump blood through the lungs. This extra effort eventually causes the heart muscle to become weak and fail. Again, shortness of breath is one of the first symptoms. You may have blue or gray skin color due to low oxygen levels. You might have chest pressure or pain, dizziness or fainting smells, fast pulse or pounding heartbeat, fatigue, swelling in the ankles, legs, and belly area. There are quite a few types of pulmonary hypertension. Group 1 is idiopathic. They don't know what has caused it. Group 2 is caused by left-sided heart failure. Group 3 can be caused by lung disease, scarring of the lungs, chronic obstructive pulmonary disease. Sleep apnea is a well-known cause of pulmonary hypertension. And then long-term exposure to high altitudes in people who may be at high risk of pulmonary hypertension. Type 4 is caused by chronic blood clots or blockages in the pulmonary artery. And type 5 is triggered by other health conditions. So we want to talk about staying healthy and monitoring yourself. Much like your car, you need to keep your body tuned up. This will keep it running to its full capacity. Being aware of subtle changes that may occur in your body will prevent possible breakdowns. You're going to want to keep an assessment log, which we have given you in your binder. This is a record of how your body is functioning from day to day. And this lets you react to specific changes that can damage the body if left untreated. Not only can you react, you can react quickly. So your daily log should include your temperature. You want to get the most consistent temperature possible when your body is at a resting state, which equals a low metabolic rate. Your temperature will be constant from day to day. It's usually upon awakening before you eat or drink. 2 to 3 degrees greater than your normal is a fever, and you should call your physician. They actually did a study a few years ago, Stanford did, and it was a long-term study. They went through historical record keeping from the Civil War, World War I, World War II, Vietnam, and the first Gulf War. And they found that over the course of 100 years, our body temperatures have actually dropped by a degree. So where 98.6 was textbook normal, in reality it's now 97.6. And if you have a lower temperature like this, when you keep track of it, you can tell your doctor, hey, for me, 99.6 or 100.6, that's a fever. And you can show them with that data. Your doctors are gonna love the data. The logs that we've given you, I hear time and time again how much the doctors appreciate those. It's going to include a peak flow. Measuring your peak expiratory flow rate lets you measure the ability of your lungs to push the air out. If the measurement drops, it may indicate possible lung swelling, an increase in mucus production, an increase in muscle airway tightening. Call your physician if your number drops by 50 to 100, approximately 20% below what is normal for you, especially if it's associated with a change in another clinical sign or remains unchanged after taking a bronchodilator, which would be your rescue medication, your albuterol, your levalbuterol. So how to use it? You're going to move the marker to the bottom of the numbered scale. You're going to stand up straight or sit straight up in a chair if unable to stand. You're going to take a deep breath, fill your lungs all the way, And then you're going to hold your breath while you place the mouthpiece in your mouth and between your teeth and close your lips around it. Do not put your tongue against or inside the hole. Blow out as hard and fast as you can in a single blow. Your first burst of air is most important, so blowing for a longer time will not affect your results. Write down the number you get, but if you coughed or did not do the steps right, do not write down the number. Instead, do the steps over again. You're going to move the marker back to the bottom and repeat all these steps 2 more times. The highest of the 3 numbers is your peak flow number. Write it down in your log chart. The PFT is measured in, the peak flow is measured in increments of 10. Yours is going to start at 60, and it's going to go up by 10s. So as you can see on this chart, 60, 70, 80, 90, 100. So this person would blow a 220 because it's to the top of that, to the bottom of the second line. I'll go ahead and show you how to do it. Let's see. Okay, this is not working. Shoot. We'll go ahead and do this when we come in. I will show all of you how to do it because this is not turning around like I thought it would. Sorry about that. I guess it does with the picture. Okay, so your assessment logs also include your weight. You want to empty your bladder before you weigh yourself. Weighing yourself upon awakening will give consistent readings from one day to the next. A weight gain of 3 to 5 pounds from one morning to the next might mean you're retaining fluid. Extra fluids can make your breathing more difficult. You're going to want to call your physician. That weight gain of that much overnight is never okay. If you are experiencing right-sided heart failure and you're retaining fluids, you might see swelling in your extremities. But if you've weighed yourself, you've experienced that weight gain, you're particularly short of breath, you may be experiencing left-sided heart failure where fluid backs up into the lungs. You're going to want to do your pulse. You're going to want to find out what's normal for you. So you're going to take it at rest. And again, you're going to do this upon awakening. Many of you have pulse oximeters, which I'll show in a sec, but it is best to do it manually if you can, or especially if you're seeing a fluctuation of numbers on that pulse ox. In reality, you should be checking it for a full minute because a lot can happen in that minute, but you can check it for 15 seconds and then multiply by 4. You can check it at your neck or on your wrist. You're going to want to feel for the rate, the rhythm, the regularity, and the strength of pulsation. So the rate is simply the number of beats per minute. The rhythm is the tempo. It may be 50 beats a minute, but it's slow and steady. It may be 100 beats a minute, but it's fast and steady. And again, that regularity. Is it an even tempo? I'm beating this. It's moving. That's fine. You don't want no beat. So you want it to be the same regularity. And then the strength of pulsation. Can you hardly feel it? Is it bounding? So you've probably experienced all those. Sometimes we'll call it thin and reedy, and that has to do with the like dehydration. You're going to want to tell your doctors if your pulse becomes irregular or changes by greater than 20 beats a minute. But just know that new meds can change your pulse. Oxygen saturation. This one's 20 bucks on Amazon. They're not that expensive. I've even bought them on Groupon. There's some that ship per piece, but others you could buy like 2 or 3 and only pay 1 shipping. So I've bought them for $5 a piece and then paid a flat $10 for shipping. It's always a good idea to have a couple of them. It doesn't do you any good to have it at home if you're out and about and experiencing shortness of breath. So this is what it measures. Oxygen is carried by the blood, carried to the body, by the hemoglobin. The pulse oximeter shines a light through your finger or earlobe. It measures the amount of hemoglobin in the red blood cells that has oxygen bound to it. By calculating the amount of light absorption in the blood, the device can measure how saturated the hemoglobin is with oxygen molecules or O2, SpO2, your oxygen saturation. It also will provide that pulse rate. And it may say HR, PR, or just show the heart. So really important to know your oxygen saturation level. Normal oxygen levels in the blood are measured at 80 to 100 millimeters of mercury. This correlates to an oxygen saturation of 92 to 100%. When your saturation drops to 90%, that is equivalent to a measurement of 60 millimeters of mercury in the blood. The drop in oxygen saturation is gradual between 92 and 100%. It declines rapidly once it is less than 90%. So it's important to monitor that saturation and do what you need to do to keep it greater than or equal to 90%. That could be pursed lip breathing or putting on oxygen. And then finally, your blood pressure, if your doctor has advised you to keep track of it, or you're currently on medication for blood pressure. We like the fitted cuff. They're still around $50, but they do make it easy to put on yourself to get a tight fit so you get a more accurate reading. Omron is our preferred brand. That's the ones we use here in the gym that are wireless. They also have ones that are corded, and I can show you those when you come in. So this is what your log looks like. The date, your temperature, your peak flow, your weight, your saturation and your pulse, and your blood pressure. Exercise is going to keep you healthy. Your goal is to exercise a minimum of 3 times a week, and the rehab classes count. Try to gradually increase the amount of time spent exercising each week. Focus on your correct breathing techniques rather than on how fast you can exercise. You want endurance. So how do you know if an infection is occurring? You have an increase in the amount of mucus. You have an increase in the stickiness of the mucus. You have a change in the color of the mucus. Drinking enough fluid, if allowed, and doing controlled coughing will help you bring up mucus so you can check it. You may have an increase in shortness of breath. Remember, you want to be able to quickly identify when symptoms change. This can prevent illness or an exacerbation, which is a fancy word for a flare-up. If you keep track of your health each and every day at the same time, you'll be able to stop an illness from the start before it's too late. We've given you a breathing zone handout. Every day is the blue zone. You're going to follow your normal routine and then determine what breathing zone you're in. You want to be green. Everything is fine, everything is normal, you're going to go about your day. If it's yellow, which includes more shortness of breath, increased heart rate, decreased saturation, this zone is a warning. And then the red is an emergency. The 2 major signals that your doctor will want to know about: Any changes in your symptoms, especially if it lasts more than 1 day, and any new symptoms that you develop. So 2 symptoms, 2 days, you're calling. It's normal to have good and bad days, but changes in new symptoms need to be brought to your provider's attention. He or she may want you to get in touch at once when 1 or more of these occur. So more shortness of breath, more trouble breathing or wheezing than usual, more coughing, an increase in mucus production, a change in the color of mucus. Does not need to be green. So if you're clear and it's yellow, that's a problem. You're yellow and it turns gray, problem. Green, bloody, problem. Even the tint of the mucus. So there, especially like bronchiectasis, may have a light green mucus, which is normal, and the green gets darker. So any color change. Swelling in your ankles, legs, or around the eyes, that sudden weight gain. Heart palpitations or faster pulse than usual. Dizziness, sleepiness, headaches, vision problems, irritability, and trouble thinking. Loss of appetite. Dehydration. A fever over 101 or 3 degrees greater than your normal. Early morning headaches not relieved by mild headache medications, especially if you're on oxygen while sleeping. And then new or increased depression. COVID is still a thing. And these are the main symptoms. Symptoms can develop 2 to 14 days after exposure, but around 5 days for most people. Remember that a cold or respiratory infection can be more serious for you than for someone who doesn't have chronic lung disease. You could get very sick and might need to go to the hospital. It's impossible to prevent infection completely, but you can take precautions to reduce your chances of getting sick. So that includes getting vaccinated, and you're going to ask your doctor if you're a good candidate for vaccinations. You can get these from your doctor, clinic, or pharmacy. You want to get a flu shot. You want to get the pneumonia vaccine. You want to get up to date on all suggested vaccines, COVID, shingles, RSV. RSV should be up there with pneumonia and flu. Very important. All respiratory diseases, all things that can affect the healthy lung tissue that each and every one of you still have. You're going to want to wash your hands. Germs spread through touch, so you want to try to keep your hands away from your mouth and face. Wash your hands often. You can use gel or hand sanitizer if they're not visibly soiled. But if they are, you're going to want to use soap and wash for at least 20 seconds. This is just a little. Use the hand sanitizer between washings. Keep one in your car so that when you get in and out, you can clean it. Remember, you're cleaning your hands too when you come in and out of the gym. So you've done everything you're supposed to do. You've kept your log. You've taken your meds. You've monitored your symptoms. And you need to go to the doctor because you're sick. Now what? Be concise and be precise to the staff and doctor alike. The staff is key to getting into your doctor. Tell them exactly what you need to be seen for and don't be shy. This will also determine the length of the appointment. Bringing a laundry list to an appointment where you're there for infected toenail is not going to get you the service that you want. Doctors book their appointments based on what you have told them. So you're going to say, hey, I have this, and this, especially if you're going to your GP. If you have lung infection and you don't, and you do see a pulmonary doctor, call their office first. A lot of them have nurse practitioners, PAs that can offer same-day appointments. Don't be afraid to see a PA or an MP. They're very good. They often end up giving you more time than a doctor would. You also want to give them exactly what you're calling for if you keep the log. So you can say something like, hey, my fever's normally 7.6. My temperature, I'm sorry, is normally 97.6. Today it's 100.4. I have green mucus instead of yellow mucus. And my peak flow meter is this instead of that. It's best to bring someone with you if you can. Take notes. If you don't understand what the doctor is saying, then ask your doctor to explain it in a way that you understand. Speak up. Don't be meek and mild-mannered. If you don't understand it again, say, hey, tell me that in simple terms. And finally, remember that your doctor is providing you a service. Don't be afraid to switch if you don't like that service. Well, thank you for this first session. I am sorry I couldn't show you the peak flow, but I will make sure to show it all to you this next week when you come into the gym. Thank you.